So we are going to discuss the megaloblastic anemia in this section. We are having a scenario that parents brought their 4 years old child with history of pallor and easy fatigability for the last few months. On examination, her weight is 11 kg and she has severe pallor, no lymphadenopathy and organomegaly, but has few bruises over her body. Her dietary habits are extremely poor, eating only potatoes and noodles, and HB is 7 mg per dl with MCV 110 and total leukocyte count with 4000 platelets count and special smear size RBCs with hypersegmented neutrophils. So here we are having the clinical features that the RBCs are large and hypersegmented neutrophils are present, and the HP is decreased, that is 7 mg per dl, and she is having dietary habits, poor dietary habits. She is only eating potatoes and noodles. So this is the megaloblastic anemia. We are having a definition that it is macrocytic anemia which is caused by the deficiency of vitamin B12, that is cobalamin, folic acid, or both, and the causes are dietary insufficiency and intestinal malabsorption, that is Crohn's disease, chronic pancreatitis, bacterial overgrowth of the small intestine, infection with the diphyllobothrium latum, that is fish type worm, and surgical resection of the terminal ileum. And pernicious anemia, which is the cause of malabsorption of vitamin B12 due to deficiency of intrinsic factor, and decreased vitamin B12 due to inborn errors, for example transcobalamin 2 deficiency and methylmalonic aciduria. Now, the clinical features of megaloblastic anemia are there. Pallor is present, weakness and fatigue is present, and there is decreased exercise tolerance. Tachycardia is present, tachypnea is present, angular chelosis is present, atrophic glossitis is present, and neurological manifestations are present, that is ataxia, hyporeflexia, and positive Babinski reflexes. Now, the investigation options for megaloblastic anemia. These are CBC, in which MCV and MCH is done, it will be raised. Numerous microovulocytes with anusocytosis and pakilocytosis on peripheral blood flow will be present. Neutrophils will be large. WBC and platelet count usually normal in mild deficiency, and it is decreased in severe cases. Bone marrow shows erythroid hyperplasia with large erythroids and myeloid precursors, and serum indirect bilirubin may slightly raised, and abnormal Schilling test is present, that is characterized by impaired absorption of vitamin B12. The treatment options are that folic acid is given, which is 1 to 5 mg per day for 3 to 4 weeks for vitamin B12, 1 mg intramuscularly for 2 to 4 days, not given in vitamin B12 deficiency. Oral or parenteral vitamin B12 is given, replacing the nutritional deficiency and treating the cause. These are the treatment options for the megaloblastic anemia. Okay, so we have discussed the megaloblastic anemia, and we have the clinical features that there are poor dietary habits, and the patient only eat potatoes and noodles, and the HB is decreased, and there are hypersegmented neutrophils. So megaloblastic anemia is macrocytic anemia, and it is caused by vitamin B12 cobalamin deficiency and folic acid deficiency, or both. The causes are dietary insufficiency, intestinal malabsorption, pernicious anemia, and decreased vitamin B12 due to inborn errors. These are the clinical features, and then we have discussed the investigations and treatment options. Okay. This was all about the megaloblastic anemia. Megaloblastic anemia. Okay. Now, in this section, we are going to discuss the acute lymphocytic leukemia, and which is the last topic of hematology. Okay. So, acute lymphocytic leukemia, these are neoplastic diseases. And we are having a scenario that there is a 5-year-old baby who is unwell for the last 2 months, and illness started with fever and epistaxis. He has only antibiotics. Okay, he has taken many antibiotics, but there is no improvement. On an examination, he is pale looking with few bruises all over the body, and cervical and axillary lymph nodes are also palpable, and he has hepatosplenomegaly. So, what is the diagnosis, the investigations, and the important differential diagnosis, and what factors predict prognosis in acute lymphocytic leukemia? Okay. Mm. Another scenario is that there is a 7 years old boy unwell for last 1 month and he is having high grade fever and weight loss, and he also complains of pain in legs, and he has used many antibiotics but no improvement in fever. On examination, child looks pale. There were multiple bruises on body on abdominal examination, and child looks pale on abdominal examination. There was huge hepatosplenomegaly. So these are the features that there is a baby who is unwell, and illness started with fever and epistaxis, and he has many antibiotics but not improvement. This is the main point, that there is no improvement with antibiotics, and the patient is pale looking, and bruises are present over the body, and cervical and axillary lymph nodes are palpable. This one is also a diagnostic point, and he has hepatosplenomegaly. 75% of the childhood acute leukemias and malignant or blast cells morphologically resemble primitive precursors of the lymphoid cells. The causes of ALL are ionizing radiation, cytotoxic drugs, oncogenic viruses, genetic factors, chromosomal instability, and immune deficiency state. The classification is that there is L1, L2, and N3. In L1, cells are small, uniform blast, and nucleoli are small, and distinct cytoplasm is scanty. The L2 cells are large, variable in size. One or more large nucleoli are present, and cytoplasm is abundant. In L3, the cells are large, regular in size, and oval or round in shape, and one prominent nucleolus is present, and cytoplasm is abundant, deeply basophilic, and it contains vacuoles. Now, the differential diagnoses are aplastic anemia, myelodysplasia or hypocellular leukemia, leukemia reaction, infectious mononucleases, ITP, lymphoma, and local infections. The investigation options are TDT, that is deoxynucleotide transferase positive in both B and T cells, CD10, that is pre-beta cells only, and T12 ratio 21 in better prognosis, and if it's 9 ratio 21, then Philadelphia chromosome, and it have poor prognosis. These are the investigation options, and these things detect that whether the prognosis will be good or not. Then the treatment options are supportive treatment, that is blood transfusions for anemia, platelet concentrations for thrombocytopenia. Antibiotics are given to control the infections, and allopurinol is given to guard against the development of uric acid nephropathy. Analgesics are given, adequate fluids are given, prophylaxis for malaria is done, and psychological support is provided. The specific treatment is the induction of remission, that is 4 to 5 weeks, when Christine dexamethasone, prednisolone, and L-asparginase is given. Irradiation for mediastinal masses and spinal tumor is done. CNS prophylaxis intrathecal methotrexate is given. Cytarabine and hydrocortisone is given, and consolidation treatment is provided. Okay, so consolidation treatment given after the induction therapy, and the injection asparginase and cyclophosphamide is used. The maintenance therapy is 6 marsuptopurine methotrexate and vincristine and prednisolone. The bone marrow relapse is bone marrow transplant and multiple drug reinduction, that is intensive chemotherapy and CNS irradiation. The local tissue reflex is that CNS irradiation, intrathecal methotrexate plus reinduction therapy, and for testis irradiation plus reinduction chemotherapy, and bone marrow transplant is done. So up till now we have discussed the acute lymphocytic leukemia and the megaloblastic anemia. So we have revised the megaloblastic anemia and hemophilia. Okay, so let's revise the ALL. We have discussed the scenario that there are few bruises and palpable lymph nodes and hepatosplenomegaly and weight loss. So this is the diagnosis is ALL, and it accounts for 75% of childhood acute leukemias, and it is malignant or blast cells morphologically resemble primitive precursors of lymphoid cells. These are the causes: ionizing radiations, oncogenic viruses, chromosomal instability, cytotoxic genetic factors, and immune deficiency state. This is the classification. This is L1, L2, and L3. And these are the differential diagnoses, that is aplastic anemia, myelodysplasia, leukemia reaction, infectious mononucleases, ITP, lymphoma, and local infections. These are the investigation options, that is TDT, deoxynucleotide transferase is positive in both B and T cells, and CD10 and pre-B cells only. And if it is T12 ratio 21, then it has better prognosis, and if it is 9 ratio 22, then there is poor prognosis. A treatment is supportive and specific in supportive blood transfusions, antibiotic, allopurinol, analgesics, adequate fluids, and prophylaxis for malaria and psychological support is provided. And in specific, induction of remission and CNS prophylaxis, consolidation treatment, maintenance therapy, bone marrow relapse, local tissue relapse, and bone marrow transplant. These options are done in the case of acute lymphocytic leukemia. Okay, the only topic that is remaining is hemophilia A, and we are having a scenario for hemophilia A that is 10 weeks presents with post circumcision bleeding for last 4 hours, and mother is worried as her brother had also the same bleeding disorder that died at age of 11 years. Uh, he is in distress with severe pallor and weak thready pulse. So the definition is that hemophilia is X-linked inherited disorder and it is a disease of intrinsic pathway coagulation defect. The classification is hemophilia A, B, and C. In A, there is deficiency of factor 8 and PTT is raised and X-linked recessive. In hemophilia B, factor 8 is deficient and prothrombin time is increased. In hemophilia C, C11 factor is deficient and there is autosomal recessive disorder and PTT is raised. Investigations are positive family history, APTT is prolonged, clotting time is prolonged, and factor 8 is decreased. It is less than 40% of the normal. The treatment options are prevention of trauma, avoid aspirin, immunization, supportive care, desmopressin, and fetal plasma proteins, anti-fibrinolytic agents, that is transaminic acid, and factor 8 is given, factor 9 and factor 11 for concentrate C. Factor 8 dose desired level percent into weight in kg multiplied by 0.5. This is the amount of the dose that is given, that is the desired level in percent multiplied by weight in kgs multiplied by 0.5. Fresh frozen plasma is given, that is 75 to 125 units of factor 8. The complications of hemophilia are that there is intracranial hemorrhage and hemarthrosis and large hematoma, that is decreased compartment syndrome and infection.